Now, it's depressingly easy to get a diagnosis of depression. 10% of all Americans are depressed at any given point in time. We don't really believe in this, and it also takes very little to get the diagnosis. If you have had little interest in 8 days out of 14 in doing things you usually do, plus one additional symptom, which can be troubles with sleep, eating little or much, which a lot of people do nowadays, or that you are running around more than usual, which could be because you just got a big grant from a funder. Well, imagine a boy whose girlfriend just left him. He will feel miserable for all 14 days. He can't sleep, he can't eat. So he's depressed and can get a pill for his depression. This doesn't make sense. So the criteria for depression have been lowered very much over the years. So when people tell you there are more depressed people today, you can't believe in this because it's not the same as it was 30 years ago. There are not more seriously depressed people today than there were 30 years ago. Now, bereavement has been seriously criticized. In the old version of the diagnosis manual, you were allowed to feel sorry for 1 year. Then it became 2 months, and then it became 2 weeks. So I asked, why not 2 days in the next version? Of course, a doctor doesn't treat patients like that, seeing that you are sad and then look up in the diagnostic manual and say, oh, we'll need to wait another 9 days before I can treat you. That's not how it works. People are usually treated immediately. And I ask myself, why can't psychiatrists get enough? We often hear that they should get more money. But really, if they didn't treat so many patients, I think there actually are enough psychiatrists. Do they have any benefits, these antidepressants? That seems like a heretic question. The FDA did a huge analysis in America, 100,000 patients in placebo-controlled trials, and half of them were depressed. And they concluded that 50% responded on drug and 40% on placebo. Now, don't think the 40% is a response to a placebo. And why not? Because if you hadn't done anything, not given people an inert pill, most would also have improved, because that's the spontaneous course of depression. It's not the effect of getting a placebo pill. The reason I tell you this is that when I have criticized these drugs, then psychiatrists have often told me, well, they aren't so fantastic, but then at least the patients benefit from the placebo effect. So therefore, it's important to say this is not correct. You can only know what the placebo effect is if you have compared with a group where you did nothing. You see? So this is pretty important to know. Now, this effect is much exaggerated. It has been measured on highly subjective depression scales, and one of my senior researchers collected all trials in the world literature that had both a blinded and a non-blinded outcome assessor, because he wanted to see how much does the non-blinded assessor exaggerate the effect compared to the blinded assessor. So this was in all disease areas. There were just 21 trials in the whole world. What he found was that the non-blinded observer exaggerated the effect by 36% on average. That is pretty much. What does this tell you? That if these trials are not adequately blinded, we exaggerate the effect pretty much. What if the blinding has been broken for all patients? Because these patients get dry mouth and blurred vision and all sorts of things. Their sex life gets destroyed in many of them. So many of them know whether they're on drug or placebo. Now, if we have broken the blinding in all of them, the 10% effect becomes 0. But you don't need to break the blinding in more than 5% if this leads to misclassification every time. Because then 40% on placebo becomes 45, 50% on drug becomes 45. So you don't need to break the blinding very much, because psychiatrists and patients want to be positive and report positive results. Now, here comes the most important Cochrane review ever made by a UK psychiatrist, Joanna Moncrief and colleagues. They reviewed depression trials where something was put into the placebo to blind them better, namely atropine, which gives you dry mouth, just like antidepressants can do. Now, what did this review find? Well, an effect that was so small that when you translate it to the Hamilton Depression Scale, it was just 1. And what does that mean? That's a scale that goes up to 52, so that basically means no effect. Why? Because another psychiatrist has found out that 5 to 6 is the minimum difference that can be perceived as a difference. So 1 out of 5 to 6, which is the absolute minimum, is really nothing. So these drugs don't work if you put something in the placebo. That's a very important finding. Why are these trials so old, from the 60s? Because the drug industry does placebo-controlled trials. They don't want to put something into the placebo, because then we could all see that the emperor has no clothes. For a lot of drugs, not only psychiatric drugs, but for a lot of drugs that just don't work. It's just bias. They are flawed. So we should do trials this way. But even if we look at these biased trials that weren't adequately blinded, then the effect is very difficult to see. These are the poorly blinded trials, and there are several meta-analyses here. And what you can see is that something called the standardized mean difference is 0.25 when the psychiatrist evaluates the effect. That corresponds to a Hamilton score of 2, which doesn't matter. And when the patients in the same trials evaluate the effect, it is almost 0. So why are the psychiatrists more positive to the drugs than the patients are? And whom would you believe? Well, I would count on the patients, of course. They are the best judges to say, does this help me or not? Antidepressants don't help patients, not even in biased trials. Now, here is a review of how quickly people improve when they get antidepressant drugs, fluoxetine or venlafaxine. What you can see is that in the beginning, on average, they are severely depressed with a Hamilton score of 21, and then they go down over the weeks, both in the drug group and in the placebo group. And it goes down pretty slowly. Now, how much time does it take before they become mildly depressed? That's down here around 13. It takes 4 weeks. Now, how much longer does it take before placebo-treated patients also become mildly depressed on average? About a week longer. And these trials are seriously flawed because nothing was put in the placebo. So what we have here is, and these are data from the companies themselves, and they don't always publish negative trials. That's another reason why these data are too positive. But if we think about what if something had been put in the placebo, then it would have been a matter of a few days. So can you understand why I think we should not treat depression with antidepressant drugs because they don't work? I mean, you can wait another couple of days and then you're equally fine on nothing as on drug. Why should we use these drugs? Because they have very serious harms, which I will come into in a minute. But first, when it's very doubtful whether a drug is of any benefit, and all drugs have harms, then a good outcome is to see, do the patients leave the trials less when they get active drug as when they get placebo? Because if they stay in the trial longer, they might get some benefit compared to the side effects, you see? But they leave the trials equally often and quickly when they get active drug as when they get placebo, and these trials are biased. So this also tells you a story about, if you ask the patients, they don't like the drugs. After only 2 months, half of the patients have already stopped taking the drug. And the chemical imbalance lie is unfortunately being actively used by doctors to convince patients who experience harms to go on with the drugs, hoping you might be better in some weeks. So they stay on the drugs, and when they then want to come off them, they might not be able to stop because then they have become dependent on them. I will come back to that. So the chemical imbalance is seriously harmful. I wish to underline that. Bob didn't say that, but it's seriously harmful to use this myth. Now, when these new antidepressants came on the market, no one liked them. The German drug regulator said that fluoxetine is totally unsuited for the treatment of depression, and the Swedish psychiatrists, they laughed when the director of Eli Lilly presented fluoxetine for them. But one of them didn't laugh so long, because the director found out who it was who should write a report for the Swedish drug agency. And this man suggested himself how many dollars it would cost to write a positive report. Of course, unknown to the tax man, some secret bank account, and also some additional money for his research. It's widely known who that man was. And he made a great career later, despite the corruption. He became assessor for Sweden, a very high position. It didn't harm his career. Now, I don't think these drugs work. I think it's all bias that we measure. Of course, some people might feel a little better because they can be a little euphoric. But other people will feel worse. And that makes an average of 0. Now, many patients and doctors think they work, but they forget about that people would become better anyhow. This is the so-called clinical experience that some psychiatrists value very highly. When I debate with them, they say, my clinical experience is that, oh, these drugs are fantastic. But it's useless. When you don't know what would happen if you did nothing, you cannot trust your clinical experience. And do they have effects on outcomes that really matter? Namely, get people back to work, save relationships, particularly intimate relationships. There are thousands of trials, and I've seen reviews of all these trials. I have never seen trials that measured exactly why we want to treat depression. So either it has never been studied, or it has been buried in company archives because it didn't look too good. Okay? But do these drugs save intimate relationships? I don't think so, because they cause sexual problems in half of those who didn't have a sexual problem before they started. That's not likely to save intimate relationships. And it's common in psychiatry that if anything happens, you always put the blame on people and not on the pills. This also happened here, that female anorgasmia was coded by the companies as female genital disorder. It's your fault. It's not our pills' fault. Eli Lilly said that only 2% become sexually disturbed, but there are several studies that show it's about half or even more. Here is a Spanish study where you can see that people get decreased libido, and even 57% couldn't get orgasm or even an ejaculation. That's really... So these drugs do something. Prevent a male from ejaculating. That's strong stuff, really. Really strong stuff. But they don't work for depression. Okay, and some patients, they yawn during orgasm. It's okay, you know, the old films where they took a cigarette afterwards, and it was okay to yawn afterwards, but not during your climax. It doesn't help a new relationship. Why are you yawning? I don't know. Did you also yawn with other women? No. So you don't like me? Yes. So why are you yawning? I don't know. Very bizarre side effect. Now, let me tell you, when I lectured in Australia for child psychiatrists, one of them told me, I know about 3 boys who could not get an erection because they were on antidepressant drugs the first time they tried to have sex. And you know what these boys did? They tried to kill themselves. They thought, of course, something was wrong with me. How could they know it was the pills? So it has a consequence to use useless drugs that have harms. Now, dependence is an important factor with these drugs. For citalopram, for example, the UK package insert says that in clinical trials, adverse events seen on treatment discontinuation occurred in approximately 40% of patients treated with citalopram. And then comes a gigantic British understatement. Recommended that the dose is gradually reduced over a period of at least 1 week. Some of you in the audience will know it can take months or years to get rid of an antidepressant drug, and quite many patients never succeed with that. So this is really some British understatement. But these are regulators. They are too much on industry's side, always. Now, I had a PhD student who's here today. She found out that withdrawal symptoms are very similar for benzodiazepines, mother's little helper, and modern antidepressants. For 37 or 42 identified symptoms, they were actually the same. But psychiatrists and industry tried to tell us, no, you don't get dependent on SSRIs, only on benzodiazepines. Why? Because the American psychiatrists introduced new criteria for what it means to be dependent just before the new antidepressants came on the market. So psychiatrists now tell me, well, you can't become dependent on SSRIs because one criterion is that you must crave higher and higher doses. And then I say, great, so no one is dependent on cigarettes because they smoke 20 every day. They don't crave 40, 60, and 80, so great. It will be easy to stop smoking. So this is insane to say that they don't get dependent. And if you ask patients, they will tell you, half usually will tell you, yeah, we do get dependent and it's difficult to stop. Now, the regulators said in 2003 that these drugs are not addictive. But the same year, the WHO actually published a report that noted that 3 SSRIs, fluoxetine, paroxetine, and sertraline, were among the top 30 highest ranking drugs for which drug dependence had ever been reported. And now we are also talking about morphine and other opioids. 3 of them were in there. And GlaxoSmithKline finally changed its revision of the risk of withdrawal reactions. It went up by a factor of 100, from almost nothing to 25% in the information for patients, but in small print. They did not advertise this and said, we are sorry, we have fooled you, we were wrong. Here is a study by Eli Lilly that tells you what happens if you stop an antidepressant abruptly. These people had remitted depression. They were well. And they had been well for at least 4 months, up to 2 years. And then suddenly a placebo period was inserted for 5 to 8 days instead of active drug. And the patients didn't know when that happened. The psychiatrists didn't know. So what happened? Eli Lilly funded the study, obviously because their drug, fluoxetine, has a metabolite with a long half-life, 1 to 2 weeks. So fluoxetine will give you less problems than other drugs because the drug stays in the blood for quite long, okay? And what you found if you look at sertraline and paroxetine was worsened mood. A lot of people irritability 1/3, agitation 1/3, Hamilton increase of at least 8, 1/3. What does it mean when Hamilton goes up by at least 8? That's what we would usually call, now your depression came back, but it's a fake depression. It's not a real depression. If they had been treated by psychotherapy and they were well, what is the likelihood that they will get a new depression in just 5 to 8 days? 1 in 100 or something? Very, very small. It's not 1/3. So what you see is what Bob also talked about. These drugs create the diseases they are supposed to help. And then what typically happens is that doctors will say, oh, you still need the drug, and then you get back on it perhaps indefinitely. But there is a good method of distinguishing between fake depressions and real depressions. That is, if you go back on full dose, you will often get well in a matter of hours. And you just saw how slowly a drug on depression works. And I told you it doesn't work. It takes weeks. So this is an abstinence depression. It's not a true depression you see here. And these effects, agitation can become even worse and can become what we call akathisia, which is an incredible, extreme form of restlessness where you can't, it means I can't sit still. You want to jump out of your skin. And what does akathisia do? It predisposes to violence, both suicide and homicide. So these drugs are dangerous. You should never stop them suddenly. Here are Finnish data. What happens when you start 100 patients on an antidepressant drug? Well, 5 years later, almost half of them still get an antidepressant drug. How long did the depression last 100 years ago or 50 years ago when we didn't use these drugs? It was over in a couple of months, perhaps 4 months, 5 months. How often did it come back within the next year or so? Not very often. What do you see here? Corresponds quite well with the fact that half of the patients say it's difficult to stop these drugs. We have created an epidemic of drug use. Think of the title of Bob's second book, An Anatomy of an Epidemic. That's what we have done. So I won't say much about the chemical imbalance hoax. We have already discussed that. But now, what we really want with treating depression is to prevent suicide. These drugs don't prevent suicide. In the FDA's big analysis, you could see that up till age 40, these drugs increased suicidal behavior, and then when you were older, it seemed to decrease suicidal behavior. But, well, when the FDA published these findings, they looked even better, because now it was only risky up till age 25, and when you were about that, well, it looked, well, maybe they had a small protection against suicide, but this is not correct. I have studied this in much detail. My book is full of this, and I will give you some examples. Suicides are far worse than what the FDA reported. There were 5 suicides on 50,000 patients on active drug. That's 1 per 10,000. I found minor materials also based on randomized trials that were part of the FDA's big analysis, 5 suicides, 9 suicides, and look, the incidence was 13, 14, and 17 instead of 1. And the person who was in charge of the big FDA analysis, as you can see in the first line, reported 1 suicide per 10,000. But 5 years earlier, the same guy, all alone, published an article also based on FDA trials where he reported 10 per 10,000, namely 22 suicides in just 22,000 patients. So where went all the other suicides in the FDA analysis? Gone. How can you get rid of suicides? Well, there are many tricks, but I think there should have been 15 times more suicides in the FDA analysis. And this is why I think these drugs are probably harmful for everyone. There is no upper age, I think, where these drugs cannot increase suicides, but I don't have the evidence. I can just tell you that the evidence we have is incredibly unreliable. People have hidden things. Now, the FDA only counted events occurring within 24 hours after stopping the drug. You have just seen that if you stop a drug, you can get depressed. It's an abstinence symptoms, so this is wrong. And also, people with agitation, which predisposes to suicide or akathisia, they were put on benzodiazepines to calm them down. What does that mean? The risk of suicide drops because they get calmed down, so they are not so akathisic. So we don't even know what the true effect of these drugs are, not only because they are not well blinded, the trials, but also because likely more patients got benzodiazepines in the active group and the placebo group. Do benzodiazepines work for depression? Well, I'm doubtful to most things in psychiatry, but if you look at the flawed trials, well, yes, they do seem to work for depression, but whether it's true or not, I don't know. I haven't studied this in detail. Now, and many suicidal events were coded as something else. For example, lack of effect or hospital admission, although the reason for the admission was that the poor guy tried to commit suicide. It wasn't apparent in the articles. Or emotional lability. We have had that at home with our daughters and ourselves. Emotional lability, all families know about that. You don't get suicidal by that, not usually. And only people at very low risk of committing suicide were recruited for the trials. Now, if the drug companies had truly believed that their drugs protected against suicide, why would they recruit people where they were pretty certain they wouldn't find this? That doesn't make sense. So I don't think they believed in it. Now, there are two big flaws in actually all psychiatric trials. Patients are usually always in treatment with a similar drug. Then you have sometimes a short washout period, typically up to 1 week, and then you randomize. Those people who get abstinence symptoms in the withdrawal period, then the washout period, they're usually discarded. They're not randomized. Bias number one. Those who are randomized, they might get abstinence symptoms later than 1 week. So what do? You introduce harms in the placebo group. They get abstinence symptoms, and then you say, our drug works. But these trials are deeply flawed. And then you ignore events after treatment was stopped, and you can see what that means here on sertraline in adults. This is not children, this is adults. Suicides and suicide attempts, the big FDA analysis, only follow up 24 hours after the trial was stopped. Well, a slight decrease in the risk of suicidality. But when Pfizer looked at their own data, it looked much better, of course. Back in-house, now their drugs seem to cut suicidality by half. But Pfizer was a bit careless, because they also presented an analysis where they included events up to 30 days after people stopped the drug. What happened then? 50% increase in the risk of suicide. Don't worry so much about whether it's statistically significant or not. What you should look at are the point estimates. And British researchers who also looked at events longer than 24 hours, they found a doubling of suicide risk in adults on sertraline in deeply flawed trials. Isn't that scaring? I think it is. David Healy has had access to company files in American court cases, and he found out that Pfizer, GlaxoSmithKline, Eli Lilly, all three of them, they manipulated their studies in a most extraordinary way. If in the washout period somebody got suicidal, it was added to the placebo group after randomization. Somehow, well, the person didn't get a drug, so that's like a placebo event. And if they stopped the randomized phase and someone killed themselves down here, then it was added to the placebo group because the patient didn't get a drug. In my universe, this is fraud. What about people who have my age? Well, antidepressants seem to be very dangerous for people like me. There is a good study where people were their own control. They were at least 65 years of age. So in one period, they didn't get a drug. In another period, they did get a drug. This removes a good deal of confounding, that it's the same patient with and without drug. And what did they find? Well, for every 28 people treated for 1 year with an antidepressant drug, there was one additional death compared to no treatment. That's a death rate of 3%. I have corresponded with the first author because this is so strong that it's almost unbelievable. Can these drugs kill so many people? She believes, yes. We did a good study. She believes it's correct. Why do they die in such huge numbers? Well, one of the reasons is that all psychiatric drugs, they affect balance because they go on your brain. Old people don't like to have affected their balance. They might fall and break a hip. 1/5 of people who have a hip fracture, they will be dead within 1 year after the fracture. That's one of the reasons these drugs kill so many people. And where do we use these drugs the most? In nursing homes, so that we can get rid of them. Sorry for my cynicism, but this is really, really bad. Not only antidepressants, but also antipsychotics and all sorts of things. This is scandalous. So my personal conclusion is we shouldn't use antidepressants for anybody. Then the psychiatrists say, well, but in hospital we have very severe depressed people that were not studied in these trials. But come on, we did study severe depression. And if you take one step further and talk about very severe depression, where is the evidence that these drugs do more good than harm in these people? It doesn't exist. It's just something they say. It's their clinical experience that we cannot rely on. And I told you these drugs can cause violence. And to the FDA, 2,000 cases of violence were reported in a 5-year period, and almost 400 of them were homicide. Now, particularly often, the drugs involved were antidepressants, sedatives, hypnotics like benzodiazepines, and ADHD drugs. Pretty scary. And here is a forensic report from a psychiatrist from Australia that looked at 10 people who had a cytochrome P450 mutation in the liver. Quite many people have that. I don't know the exact proportion, maybe 10% or so. This means that the concentration of the drug gets wrong. So these 10 people, they were put on antidepressant drugs. There was no good indication of using antidepressants. You don't use an antidepressant because your husband is drinking, or your sister had a car crash, or not making enough money to support the family. This is how these drugs are being used in practice for almost everything. It's totally wrong. And what happened? Killed teenage daughter in toxic delirium after 3 days. And when he ran out of pills, he killed his father in violent akathisia, stabbed former partner, killed son, and so on. And it just goes on like this. Any dose increase, any dose change is dangerous. When you start an antidepressant, when you lower the dose, when you stop the dose, everything you change can be dangerous. Jump in front of a train with child marital distress. Is that an indication for antidepressants? No. Harassment at work? No, it's not. And the main point is these people acted in a totally out of character fashion where they couldn't recognize themselves. And the doctors succeeded to take antidepressants from them. And then they returned to their previous normal personalities. These drugs change you. Not all, but they can change you very considerably. Now, but Whittaker already told you about the fatal flaw in maintenance studies where you have treated people successfully and then you randomize to placebo, usually without a washout period, which means you give them a cold turkey. And when you have, in one of Bob's books, he writes that for antipsychotics, actually some people became so bad they committed suicide because of the withdrawal symptoms. And moreover, these suicides were not reported in the medical journals. They were gone. And withdrawal symptoms in the placebo group are, of course, usually interpreted as disease symptoms. And I won't show you the Wundering study again, but just remind you that 7 years later, more people had recovered if they lowered the dose. And the dose in the last 2 years was 64% higher in the maintenance group than in the dose reduction group in people with psychosis. And more people had stopped drug completely in the drug reduction group, 11 versus 6, and yet their outcome was better at 7 years. So we need very, very long-term studies in order to find out what these drugs do to people. And it's not nice to see what they are doing. Now, how many people do these drugs kill? That's a bit difficult to find out. I have collected the best cohort studies I could find, and also a meta-analysis of randomized trials of antipsychotics in old people, because if you look at trials in old people, it's more likely that they were not already in treatment before you randomized a person with dementia to an antipsychotic or placebo. So these trials are more trustworthy. And they showed that when you give an antipsychotic to an old person, you kill one of them out of 100. And these trials are short-term, it's just some weeks. But you kill one in 100 in randomized trials. So these drugs kill people. Some psychiatrists will tell you, based on very poor science, no, it's the other way around. They save people's lives. Antipsychotics, they don't. They kill people. So I've calculated based on these studies, and I looked only at antipsychotics, benzodiazepines, and antidepressants, that in people aged 65 or above, I estimated that more than 500,000 people are killed annually in the USA and Europe. This makes psychiatric drugs the third leading cause of death after heart disease and cancer. I may be wrong. I have done the best I could. But if I'm wrong, these drugs still kill an enormous amount of people. This is indisputable. How few psychiatric drugs do we really need? Well, likely all drugs can cause chronic brain damage. Drug treatment often leads to addiction. Psychiatrists' silverbacks on drug company payroll have helped the companies hook more than 100 million people on drugs most of them didn't need in the first place. And when problems arise, blame the disease, not the pills. Now, I don't think we should use antidepressants. ADHD drugs you will hear about after lunch. Don't use them, they are harmful. That's pretty clear. Anti-dementia drugs, don't use them, they don't work, they're also harmful. It's just bias, what you measure in these trials. They have not been adequately blinded, these trials. You measure a very small effect, and yeah, not well blinded. Antipsychotics, I've been kind and said 8% of current usage. I actually think this is too much. Benzodiazepines, perhaps 5% of current usage at most. You know, there have been very few studies comparing benzodiazepines with antipsychotics, and they're not very good. But there is a Cochrane review on this, and it showed that more people became sedated when they had an acute psychosis on a benzodiazepine as on an antipsychotic. So I'm asking myself, do we need antipsychotics at all? We might be able to use a benzodiazepine in the acute situation. It seems to work well. I'm not convinced that we need antipsychotics at all. So psychiatry has caused an immensely overdiagnosed and overdrugged population. It's the biggest disaster on healthcare today that supersedes anything else I have seen in my life. And I'm a specialist in internal medicine. I have seen a lot, but never anything as bad as this. And with so much pseudoscience and poor science that people believe in. It's absolutely horrible. These drugs have caused hundreds of thousands of deaths over the decades and more than 100 million mental and physical cripples. over the decades. So we need to have detox clinics everywhere, like we try to help street junkies with detox clinics. We need detox clinics for psychiatric drugs. And I just called for a war on psychiatric drugs yesterday in the Daily Mail. And doctors are not educated in tapering these drugs slowly, slowly, slowly. They usually don't know what to do, so the typical attitude is arrogance. So you don't like my drugs? Maybe you don't like me? It's human, but it's wrong. So patients are often left to fend their own way through this hell that doctors have created for them. We should focus on psychotherapy. We are currently assembling particularly trials that have 3 arms: psychotherapy, drugs, or both, and then long-term outcomes. So I can't tell you about the results so far, but I can tell you about what I have seen, which is preliminary. I have seen trials that suggest to me that when you give a drug plus psychotherapy, psychotherapy isn't so effective. And there is a good reason for that. If you take away people's feelings, how can you work with them in psychotherapy? If you take away their thoughts, which you do with antipsychotics, how can you work with what they think? So it makes a lot of sense. But we will come back to that when we have collected the literature and have published it. And later I will explain to you why the most important thing we need to do is to put a ban on forced admission and forced treatment. There are studies that show that half of patients with a diagnosis of schizophrenia didn't have schizophrenia at all. Some studies have shown even higher percentages. Doctors force people with the wrong diagnosis into taking drugs that kill some of them. This is deeply unethical. It's only at war that we otherwise force people into doing something that might kill them. We must stop this insanity with forced treatment. So I'll come back to that after lunch. And I have actually become a little active in the social media. It took a good deal of courage. I won't go on Facebook. I'll let others do that. My life is too short for that. But I do have a website where I put up different things. For example, the article from the Daily Mail from yesterday, it's up there. So if you want to follow what I'm doing and my arguments, it is on Deadly Medicines DK. Also some lectures. And this lecture will be put up, these lectures today will be put up on YouTube. There are several filmmakers, and one of them will specifically put it all up on YouTube so people can see it there. Now, Bob should actually be the chairman for me, but I have 3 minutes left, Bob. And this is my last slide. It is also sad, so I will end with a cartoon. We can't find anything wrong with you, so we're going to treat you for symptom deficit disorder. Sure, we will find an excuse for giving you pills. Let's stop this insanity. Thank you.
My name is Albert Gede. I'm a neurobiologist and pharmacologist, and I have a huge interest in the topic. And again, I thank you. I thank you also for having started the debate and the discussion. And I think it's an extremely important event. And I had hoped that there would be more psychiatrists here today, but I had expected to see more people from the field. However, I have 3 questions, brief questions, if I may. One is, do you deny the existence of a disease like that we call major depression in the literature? And what, if anything, given your ban on these drugs, should we do to it? And the other question had to do with that. When I talk to psychiatrists, they say that 95% of the prescriptions for these drugs, for the antidepressives, actually come from the general practitioners and not from the psychiatrists. and that they are actually secretly quite distressed by the enormity of these prescriptions. And the final thing is that there has been no discussion in this relation of the important topic of alcohol. Alcohol is a disease. Alcoholism is a disease that apparently has sort of the same magnitude. There are about 500,000 Danes that are supposed to be dependent on alcohol. Oh. And the relationship between the prescription of antidepressives and alcohol is also documented. It seems to me that along with this campaign, there should also be a campaign that expounded the important consequences of consumption of alcohol. Thank you.
I couldn't dream of denying that some people are in very bad shape and have what we call depression. But the way we diagnose it, I have a lot of reservations. But of course there are some people that need help, no doubt about that. And I agree with you also with the alcohol problem. Actually, everything that affects the brain seems to be a problem. When I was young, and you were young, we heard, oh, marijuana, oh, it can give you a great time and you laugh all the time. But then suddenly you become incredibly aggressive and you don't recognize yourself again. That's like antidepressants. So my grandfather, who was a GP, he said marijuana is much more dangerous than people think back then in the 60s. And we now know that it is much more dangerous. And then you had the question about the GPs. You are right, usual estimates are about 90% of antidepressants are prescribed by GPs. And Paul Hvidebæk, psychiatrist in Denmark, has told me that he wanted to study in general practice what made them prescribe an antidepressant drug. And they turned their back on him. They didn't want him to find out when did they prescribe antidepressant drugs? For ingrown toenails, marital problems, a sinusitis with tinnitus. I've heard so many terrible stories. They didn't want that studied, but we need to have this studied. And I think, my personal view is, psychiatric drugs are so dangerous, and they are this double-edged sword that Bob told about. People cannot handle them, not even the psychiatrist. So therefore, we should put a ban on general practitioners. They should not be allowed to use psychiatric drugs. That would cut our drug epidemic down to much lower than it is today. It's far too dangerous to let GPs use psychiatric drugs, if you ask me. Did that approximately respond to your questions? I think, yeah, thank you.
Yes, my name is Birgitte Bækgaard, and as a psychologist and as a psychotherapist, I would be happy to confirm your suggestion about replacing medicine with psychotherapy. Unfortunately, I'm not able to do that. Many years' experiences from psychiatry with many different kinds of mental disorders, psychotic patients, non-psychotic patients in the acute stage and the not acute stages. My experience is that some people are certainly helped by psychotherapy, but we also have to say that some people can't be helped by psychotherapy. And that's not only my experiences, also the research confirmed that. I did an overview myself about psychotherapy with schizophrenic patients in medicine and not medicine, and that confirms this experience that some people are helped and some people we can't help.
Yeah.
So my conclusion is, please do not do psychotherapy to a universal treatment.
I don't think I do that. People often ask me, what is the alternative to antidepressant drugs? And I have a simple answer. No antidepressant drugs. If we could get that far, people would be much better off. That's the alternative, no antidepressant drugs. Then we can start discussing other interventions like psychotherapy. And of course, you're absolutely correct. It also depends on how intelligent and empathic the psychotherapist is. Some are very bad, some are very good, and so on. But we also have to realize we cannot help everyone. In the first page of my new book, I write that psychiatry is a difficult specialty, among other things, because if psychiatrists do their best to tell the patients how they should help themselves, because that's really how you can improve, it must come from yourself, which is another reason that psychotherapy doesn't work so well if you are drugged. But we just have to accept we can't help everybody. Thank you.
Erik Olsen, I come from the user movement, and tell also just to this lady that, of course, psychotherapy is not going to be the answer. We have a lot of experience of alternatives in the user movement, because we have, a lot of us have recovered and know how to do it. So that's another question. But I want to ask you a question, because I think it's a scandal. If 440,000 Danes are using these SSRIs, and they are in a way sterilized without their consent, they didn't go into antidepressant treatment to do this, why don't we go to the health directorate? They have to look over what is happening. But I heard, and I want to ask you this, that the health directorate, who approves the validity of medications and so on, consists of psychiatrists. And the psychiatrists there, they have to give a dispensation for those psychiatrists, because they couldn't find any psychiatrist in Denmark who were not in some way working with the pharmaceutical industry.
Yeah. First of all, the last thing you said is not true. There are more than 1,000 psychiatrists in Denmark. You can easily find someone who is not on industry payroll. You can also find people who know how to read science critically. You don't need to be a psychiatrist in order to read psychiatric trials critically. It can even be an advantage that you are not a psychiatrist, because then you are not indoctrinated. So there are no excuses, and there is no hope from our drug regulators. They are far too much on industry side, which I've just shown you the FDA is. So there is no hope there. You have seen how slow the Danish National Board of Health is. Even when psychiatrists harm their patients, it needs to come out in the press before they do anything. No hope there. My hope, and that's why I have this conference, comes from the people. It sounds almost revolutionary. From the patients and their relatives, and from young psychiatrists and psychologists who have not yet been that much indoctrinated. That is my hope. And then I try to work politically. I will do that in the coming time, to work with politicians of health in Parliament, to try to convince them that forced treatment is medieval. This must be banned, but I'll come back to that after lunch. So that is my hope, and that is one reason why I have invited 5 ladies to talk about their losses to you lost a loved one to an SSRI, to put faces to the many deaths. Because we need also not only talk about science, we need people to become angry and say this cannot go on any longer.
My name is Lise Bangsbo, and I come from Denmark and Norway. And I have a question, because when we look on the forced admission and forced treatment, why do we not use the law and human rights? Because criminals, they have a lawyer, but patients, they have no place to turn.
I will lecture about this after lunch, but now that you are Norwegian, I will tell you that I'm involved in a Norwegian court case that has been appealed to the Norwegian High Court, Supreme Court. The arguments for forcing Cyprexa into that poor guy are non-existing. I'm appalled by what happens in the courts. But let me come back to that after lunch.
Yes, my name is Anna E, and I'm making a film about Peter. So now I have a question for him. I know that you have been talking about that the people who are working at the psychiatric ward should be trained in another way. What should they learn?
Well, one thing I can definitely say, and I can quote an American psychiatrist for that, he said something about 40 years ago, perhaps half of the psychiatrists learned how to do psychotherapy. Today, almost no one is educated in this. So that's the first thing we should do. And then they should back us, those of us who want to have a ban on forced treatment because it's so harmful. That is the other major issue. And then they should say no to the drug industry completely. They should take no money, no Congress travels, no dinners, not even a cup of coffee, and they shouldn't talk to them. Why should they talk to a salesperson from a drug company? They don't tell the truth to these doctors. There are lots of things that psychiatrists could do, and they even still have international meetings that are sponsored by the pharmaceutical industry. This is completely wrong. There should be no money whatsoever in what the psychiatrists do. Empathy is difficult to teach people. If they don't have it, it's pretty difficult to give them it, isn't it?
Is it correct that between 40 and 60% of the employees in the Danish Medicinalstyrelse have economical connections with the drug industry?
I have complained to the Danish Ombudsman that the National Board of Health allows advisors who are on company payroll, and the Ombudsman didn't want to deal with my case, which is very surprising. So now we are thinking about perhaps filing a case in the European Union about this, because it's the same in all countries. And it's wrong. According to laws of public administration, you should not use such persons if you can find other experts, and this is always possible. So the Danish National Board of Health is breaking the law, and they do the same in all countries. I just can't imagine, are the laws just for you and me, and not for those people who sit in some official capacity? Well, I'll stop there. And I will now give the word to Bob Whittaker, because he will talk about ADHD. Please, Bob.